What can you tell us about the rate of ILD observed and the high-grade ILDs, and what should be done as a practical guidelines in the community to screen for it before it happens?
So yeah, I would feel it was not a surprise to see some interstitial lung disease because every trial of T-DXd since the first DB01 trial showed some degree of ILD. Although I do feel that we got better at detecting it, at treating it. And so you see clearly from Destiny-Breast01 to Destiny-Breast03 to Destiny-Breast09, kind of a stable degree of ILD, but the grades got much lower. The grade 5 got much lower. And so right now, we still see less than 1% of fatal ILD, but in truth, most agents do have some potentially fatal adverse events in rare cases, and it's kind of the counterbalance of a benefit for many patients. And so I do think what we can do, we have about 12% risk of ILD, less than 1% of grade 5. The best we can do is to monitor carefully to catch it as soon as possible and use steroids. And so what is done in clinical trials, doing CT scans of the chest every 6 weeks during treatment, that is not always feasible in clinical practice. And so in truth, most guidelines recommend every 6 to 12 weeks. There is this window that you can kind of manage. For an average patient, you can think of doing every 9 weeks and then later on moving to 12. For a high-risk patient, you may want to do 6 weeks. And so I think we can work in this window. Whenever ILD is caught, if it's asymptomatic, only radiologically detected, given steroids, but you can restart treatment if it resolves. And currently, guidelines recommend instead to permanently stop T-DXd if there is an asymptomatic, a grade 2 or higher ILD. We still don't know if this is needed. Was kind of a precaution made because there were some fatal cases. I do think at some point we'll move beyond that. We'll find safer ways to restart T-DXd, but for now, the basically black or white rule is if they have grade 1, symptomatic, use steroids, potentially rechallenge if it resolves. If they have grade 2, symptomatic, cough, shortness of breath, chest pain, stop permanently, give steroids.
And that's in the label.
Mainstay.
That is in the label. So yes, the label says.
Whereas I would say that cardiotoxicity doesn't seem to be worse with T-DXd compared to TDM1, compared to trastuzumab. It's really related to the anti-HER2 antibody. And we know that it's a mostly fully reversible cardiotoxicity. So critical to monitor for it, to do echoes every 3 to 4 months during treatment for patients. But it's not as scary as anthracyclines, for instance, so I don't feel as concerned about that.
Yeah.
Can I challenge both of you?
Please.
Question? What if those grade 1.5 pneumonitis patients, we have those patients come to us all the time. I had a hard time to call them grade 2, but I'm hesitant to call them grade 1. We call them 1.5.
And these are the one Hoprugo in her study that she showed us. These are the one that were rechallenged, but they were 19 patients. They rechallenged and they did pretty well. A 19-patient study, I'm not comfortable adopting yet in my practice, to be honest. Because ILD can be devastating, right? So that's not something that I can play with. What do you think, Paolo?
Well, I do think there's a situation where I do consider challenges when it's not clear what caused that little cough. There is viruses going around. There's many conditions. There's many things. Even just reflux can cause cough, and so sometimes it's really not clear. You have just a few tiny spots on the CT chest, and you ask the radiologist, and the radiologist tells you this will never lead to symptoms. It's impossible. And so in those cases where it's extremely mild, both radiology-wise, symptoms-wise, I'm tempted to do that, so I cannot lie. And so, of course, we have guidelines for a reason, to guide us in most cases, but most cases are never all cases. And so I think in oncology, we always need a little wiggle room for those cases that are outside of the guidelines, that are unclear, and that's the moment where we are doctors.
And you know who can help you with this? Make sure you are, on Christmas or any holiday, take a gift to your favorite pulmonologist.
Exactly.
Yes.
So you can send them to your pulmonologist.
Exactly.